Hi, gents, again. How are you? This is Muhammad Musa from AFK Study Plan. Today is Sunday, and here we go with our weekly newsletter. For who don't know about it, every day we post a question in our community, and we give the answer by the end of the day. By the end of the week, we collect the whole questions and get one presentation with this video to give you the answer, and more importantly, the topic about this answer and the concept which cover this question, so you can answer different question from the same topic. You can go down here to check, like I think in here you can check the like tag for the questions, and up in this way you can see a clip where you can press it, and then you can download the whole presentation. And on the other side you can see the other newsletter 1, 2, 3, 4, 5. That being said, let's start it. First question from pathology. A patient presented with bone pain. After radiographic examination, a cotton wool and overall mosaic pattern was observed. What clinical diagnosis is most likely? This question is speaking about a patient come to your office. He has one complaint, one chip complaint, and then one obvious stuff in the x-ray. And I would like, when you study oral pathology, for sure you need to study the disease and syndrome and everything, but I would recommend for you, for every condition, to have three keywords. You have three keywords for every condition, and then you can see there is some intersection between condition, and then you differentiate between those. You will be in a very good position. So when you speak about bone pain and cotton wool appearance, I think you can get the answer. So let's read. Gigantism, no, it's like a modification of growth. Patient after puberty, he's increasing in size. His hand, his face is different. Aminoblastoma will have pain, but not like bone pain. When I'm specifying to a bone pain, you might have some expansion, you might have root resorption or loose teeth. It's different story. Basal cell carcinoma is a soft tissue. It most commonly happen in the ala of the nose, outer of the face. And if it come with other condition, like with OKC, it will have different more clinical picture, more pathognomonic than only bone pain and cotton wool. And this is important. When you read the question, do not assume, okay, so I have this and this, so this patient might have OKC because he has basal cell carcinoma, because he's nevoid basal cell carcinoma. No, it has more sign and symptoms like spina bifida. It has more criteria to say, okay, this is this condition. So, and finally we have Paget disease, and it is a Paget disease. Let's speak about this one. So a Paget disease it represents the second most common metabolic bone disorder after osteoporosis, and primarily affect older adult of Anglo-Saxon and insanity, meaning like the people living in like England, part of Europe, they are most commonly affected with this disease. Clinical and radiographic feature: Paget disease of bone primarily affect older patient. Disease frequently increase with age, and mean age of diagnosis has been increasing in many populations. The condition is rare in patients younger than 40. Most studies report a male predilection. At diagnosis, many patients are asymptomatic, although up to 40% of patients initially present with bone pain. So patient come to you saying, I have pain in my joint, in my face. I don't know what pain is coming from. And let me tell you a funny story about this one. So the doctor who discovered this condition, his name was Paget. And he used to make denture for his patient. And he make denture, and this patient come to him after 6 months saying the denture is not fitting anymore. And then he was like, okay, let's make a new one. He make a new one for him. After 6 or 9 months, he came again, denture is not fitting. And he realized every time the patient come to the office after 6 months, he's having a new hat. Like back in this age, the hat was like something like fancy for like rich people. And then he asked him, why you change your hat? And he said, like, I feel my skull is growing more. So he thought about like maybe this condition has something to do with his denture not fitting anymore. So he tried to do more investigation about this, and he reached conclusion about this disease. The disease is a symptomatic disease, as we said, like only bone pain, may be discovered in accidentally when radiograph examination or serum alkaline phosphatase measurement. And this is the clinical picture, like the lab investigation you should do if you have your patient. You go to do serum alkaline phosphatase. It will be up in the sky. Measurement is performed for unrelated reasons. Bone pain may result from either increased bone turnover or secondary complication. So why the bone pain is happening? Because like when was this disease, Paget disease, the metabolism of bone is impaired. So the bone is like osteoblast is doing more bone and osteoclast is not working. That's why alkaline phosphatase is up in the sky, the level inside the blood for this patient. The disease arises in one or more bone simultaneously, and involvement typically remain restricted to these original sites throughout the disease course. So some patient, it might happen in the pelvis, some patient happen in the oral cavity, in the skull, it happen in his maxilla. The pelvis, femur, lumbar vertebra, skull, and tibia are involved most commonly. Affected bones become thickened, enlarged, and weakened with an increased risk for fracture. So you might think, okay, so osteoblast is doing amazing job, so this bone will be stronger. Why it has increased risk to be fractured? Because when osteoclast is working, it's not working uniform. That's why you have cotoneal appearance. Because in some foci, it's depositing more bone. And when you deposit more bone, other region will be weak area. So this weak area more susceptible to be broken if it come to have any sudden pressure, any sudden trauma. It will be has more chance to be broken. Think about like a wood, and then it's supported more from one side, and then the middle part is not supported enough. So this part is has more chances to be broken. Involvement of weight-bearing bones often leads to bowing deformity. Like for patient with femur and pelvis, you can see the bone is monkey-like stance. Skull involvement generally causes a progressive increase in head circumference, as we said, the hat condition. Deafness and visual impairment may result from nerve compression or other mechanism. So when the skull is growing, so it's compressing the sensory nerve related for hearing and visual, leading to impairment for dysfunction. Cardiovascular complications include arterial calcification and high output congestive heart failure also are possible. And here is a condition when you take the X-ray for pelvis, you can see the cotoneal appearance and you can see the deformity happening in the bone appearance here and bone pattern. Okay. Also, and let me give you this concept. Sometimes you are facing with a new type of question for oral pathology. This type of question is describing syndrome in the question and then asking you what investigation you can do to confirm your diagnosis. So let's think about this scenario in this question. So think about the same question saying bone pain and saying like patient denture is not fit, the recently made fabricated complete denture for this patient is not fitting anymore. What x-ray you can do to confirm your diagnosis? And then I will give you Waters view, lateral skull view, cephalometric, and trapezius cephalometric. And then you can think, oh my goodness, what this has to do to this? Because usually when you have this type of x-ray, we are aiming to get the fracture. So he getting you from oral pathology to x-ray, and then you are confused. When you see this type of question, because it's frequently coming in real exam, you just take a deep breath and think what you know and apply your knowledge. So this patient has bone pain, and this patient has increase in the circumference for his maxilla because the denture is not fitting anymore. So what x-ray you can see cotoneal appearance? Is it like cephalometric or anteposterior cephalometric or Watts view or lateral skull view? You can see in the lateral skull view, you can see cotoneal appearance. You can see the pattern of the bone is totally not fine. Skull involvement generally cause a progressive increase in head circumference. Deafness and visual impairment may result because of nerve compression and other mechanisms. And we speak about this one before. Jaw involvement is present in about 70% of patients with a prediction for maxilla, approximately 2 to 1 maxilla to mandible ratio. Okay? And finally, this is the PA, and this is what we're aiming for. You can see the tooth are separated, like because it's spaced apart from each other. You can see this pattern of bone. This is a cotoneal pattern appearance, and this is very pathognomonic for this condition. Maxillary disease produce enlargement of the middle third of the face and may result in nasal obstruction. And then the alveolar ridge tend to remain symmetrical but become grossly enlarged. That's why the denture is not fitting anymore. Alveolar enlargement may cause spacing between teeth, and edentulous patients may complain that their denture feel too tight. Okay, and maybe not fitting anymore. Same condition here with the same X-ray. Radiographically, in early disease stages, the affected bone exhibit decreased radiodensity. and a coarse trabecular pattern. Particularly in the skull, large circumscribed radiolucency may be present, which we call it osteoporosis circumscripta. In later disease stage, patchy area of bone sclerosis form and tend to become conflict. The patchy sclerotic area characteristically exhibit a cotton wool appearance. And this is the bottom line for this condition. I know I speak a lot about it, but this condition is important and I would like you to study it in a good way. Microscopic examinations show uncontrolled desorption and formation of bone in the respective phase. Numerous hyperactive osteoclasts surrounded the bone trabecula. These osteoclasts tend to be enlarged with an increased number of nuclei. In addition, highly vascular fibrous connective tissue replaced the marrow bone. Behind the leading edge of osteoclast activity, there is a gradual conversion from predominantly osteoclastic to osteoplastic activity. As we say, it starts as radiolucent because of activity of osteoclast eating the bone, and then go to cotton wool because it's osteoplast activity getting more bone to be radio opaque. So osteoplasts form osteoid rim around the bone trabecula, and the bone lacks an organized lamellar pattern. That's why it's more easy to be broken. Basophilic reversal lines, which indicate the junction between alternating bone resorption and formation, result in a characteristic jigsaw puzzle or mosaic appearance. So let me at the end tell you what word I will get from this condition. Diagnosis, you can see serum alkaline phosphatase is skyrocketing, and also normal blood calcium and phosphorus level. Why this line is important? Because there is other condition with bone pain and the calcium and phosphorus level is different. I would like to read what do you think, which condition has bone pain and it's a metabolic condition, but like this calcium and phosphorus is different in the level. So you say it's not this one because the other condition, alkaline phosphatase, is also increased, but the calcium and phosphorus level is giving you the differentiation between Paget and other disease. I hope you can answer it. Treatment. Paget disease is chronic and slowly progressive but seldom fatal. Asymptomatic patients with limited disease do not require treatment. Patients with symptomatic or extensive disease typically receive bisphosphonate therapy like single infusion of zoledronic acid, and pay attention to the names, zoledronic acid, oral renzonidate, or alderonidate administered daily for several months. Names are important. Why names are important? Because I will give you another scenario now. Potential dental complications include difficulties in extracting teeth with hyperphosphatase, hypercementosis, and or alkalosis, extensive hemorrhage from oral surgical procedure performed during the vascular latic phase, the radiolucent one, and poor wound healing with increased susceptibility to osteomyelitis during a vascular sclerotic phase. So think about this picture. Like, let's go to the picture so you can have some visual. Yeah, think about this picture and think you are going to extract this tooth. So what complication might happen for you? So that is saying maybe you are going to extract lower permanent first molar, and you did a BA to check the apical part of the tooth, and you see a cotton wheel appearance. So what's the measurement you should take for this patient, or what the complication might happen for this patient? So he will not give you it's a Paget disease. He will give you clinical scenario. He will give you some stuff and asking about more tests you do so you can reach a conclusion. And this type of question, I think it's not easy, but it's fair. It should test your not knowledge only, test your knowledge and analysis potential, how you can analyze the question and reach a conclusion. Edentulous patient may require a new denture as we sit for this, okay? So in treatment, Pagetic bone and a history of bisphosphonate therapy generally are considered unfavorable factor for osseointegration of dental implant, although successful implant placement has been reported in few cases. Malignant transformation into osteosarcoma or other sarcomas is a rare, less than 1%. A sudden increase in bone pain or swelling should raise suspicion of possible underlying malignancy. Osteosarcoma in adult older than 40 is quite uncommon. Most Paget-related osteosarcomas develop in pelvis and long bone of extremities. Another rare complication of Paget disease is development of benign or malignant giant cell tumor, most often involving the craniofacial skeleton. And that was all for Paget disease. So if I'm going to study Paget disease, I will get 5 words: bone pain, cotton wheel appearance, mosaic pattern of the bone, and basophilic in the microscopic pattern, alkaline phosphatase skyrocketing, and normal phosphate and calcium, and the name for medication I'm going to my patient. So these words, it will get you to a good position. So how you are going to study pathology, you read the whole condition as we did now. Do not ever read the condition without x-ray, without photos, because like reading without photos make the words go to your mind. Second day, 3 days maximum, the wording will be gone from your mind. But when you connect it to words, connect the words to x-ray to picture, it's easier to stick in your mind. And then you get a card for the condition saying this 1 2 3 1 2 3 1 2 3. So you have the wording for yourself, and you can reach a conclusion about this condition. I tried this time not to give you the answer to explain all about Paget's, because Paget's is important condition. I'm giving you a way to study oral pathology because I know this topic is tricky and you might see a lot of question in the exam about this one. Second, from management. I cannot do any newsletter without management question. I love this so much. Shortly after entering the dental office, the patient started becoming irritable, breathing heavily, and feeling dizzy. The assistant instructed the patient to breathe in a paper bag. Breathing in a bag helps too. So here, as I told you before, the new way of questions is not asking you the management. So you can say, okay, this is maybe angina, this maybe hyperventilation. He just entered the office, I did nothing for him. And then the assistant deal with him. He just asked him to breathe in a bag. And then he asking you why the assistant do this. Increase CO2 in blood, increase O2 in blood, relax the patient, distract the patient. Like we don't distract patient, we need to deal with them. Relax the patient. How come he can be relaxing when breathing in a bag? So let's discuss this topic. So this is manifestation of hyperventilation. You have dizziness, syncope, tingling, numbness on finger. Respiratory, you have a chest pain, feeling of shortness of breath, increased rate and depth of breath. And this is the most important part. For hyperventilation, the normal ventilation rate between like 12 to 20. For this patient, it might reach to 30. It might reach, like the numbers will be extremely high. This patient have xerostomia, you have palpitation and tachycardia, muscular spasm, myalgia, tetanus, and tremor. This is very extreme to reach to this patient. So when I'm going to study this, I'm going to get the specific words for this one: feeling shortness of breath, increased rate and depth of breath, palpitation, tachycardia, and then muscle spasm. And I will get this one, chest pain. I will have another paper for chest pain. Any condition with chest pain, I will write it. And then by the end of my study session, I will go. So chest pain, when I have chest pain, I go to history. History, it's angina. No history, MI. And then chest pain with increased respiratory rate, so it's hyperventilation. How I'm going to deal with MI, I'm going to do MONA. How I'm going to deal with angina, I'm going to give him nitroglycerin 3 times and wait, unless the patient has recent history of hospitalization. This is how you study. This is how you collect information, not like reading here and trying to memorize everything. Memorizing everything will get you to nowhere. You get to get the keywords because like condition intersect. Like chest pain, there is like at least I can think about now 5 conditions with chest pain. So when I say chest pain, nothing coming from chest pain. Correct? Management: terminate all dental treatment if he's in the patient in the chair. Position patient in chair in almost fully upright position, and this is one of the rarest condition when we get this upright position. Attempt to calm patient verbally. You speak with him. Have a patient breathe carbon dioxide in reached air, such as out in and out of a small bag. So why we are doing this, I'll explain now. If symptoms persist or worsen, administer diazepam 10 milligram intramuscularly. So we get diazepam intramuscularly, intravenously, or titrate slowly intravenously until anxiety is relieved. So if you're going to give 10, you're going to give intramuscularly. If you are going to give intravenously, you can give 10 right away. And the difference between intravenous and intravenous are extremely fast, getting inside the bloodstream, so you cannot inject 10 in one point. But intramuscularly, when you give it, it go into the muscle, and the muscle tend to cleave it from the muscle to the body. So you give 10 in the reservoir in his muscle, and then the muscle is charged the medication slowly into his bloodstream. Unless you are giving intravenously, you are going to tartrate it. Or administrate midazolam 5 milligram intramuscularly, or titrate it in the other way, in the same way. Monitor vital signs, perform all further dental surgery using anxiety reduction measures. Meaning like this, next time when this patient come, you have a note in his file, so we need to speak more, we need to make sure freezing is perfect, we need to make sure he has no problem. And I will explain about this topic, but I wouldn't recommend digging deep in this part because if you dig deep in this one, you will be completely lost. So I will give you whatever you need here, and please do not dig more because the more you dig, the more it gets difficult for you. So in our normal body, we have oxygen and carbon dioxide. This is how we regulate our breathing, and this is how we have peripheral receptors and central receptors to compensate if we lose someone against each other. Okay, and we have two conditions. Chronic condition, this will not speak about it, meaning like patient living in high altitude, like patient living in Bolivia, living in Brazil, in Chile, when they have altitude like maybe like 3,000 feet above the water level. So they have less oxygen. So they have different mechanism of dealing with this. I'm not going to discuss this. I'm going to discuss this acute. When there is imbalance between this one, leading to acute condition happening for a patient in the office, like the same question. It's rapid and transient physiological response. It has central and peripheral chemoreceptors. So we reach a conclusion. We have acute and chronic. Acute, rapid, transient, and we have central and peripheral chemoreceptors. So what's going to happen for our patient? So when we have imbalance in this one, central and peripheral chemoreceptors are going to kick in to try to control it and reverse the condition. In the chronic one, regulation of gene expression, which we're going to discuss. So what happened in this? Carotid artery have a receptors. These receptors is connected to our brain, and this receptors is the peripheral one in the carotid artery. These receptors detect the level of oxygen and carbon dioxide inside your bloodstream, and then when there is imbalance, they sending signals to your central nervous system through glossopharyngeal afferent fiber, cranial nerve number 9. So it's a peripheral through glossopharyngeal afferent fibers, and this is the information you should know. It goes to your brain, to the respiratory center in bones and medulla oblongata, so it can control it. And that's it. I would like you to know this part, and that's it. Do not dig deep. It's a carotid artery, has a receptor, which is a peripheral receptors. It sends message to the central receptors, which are in bones and medulla oblongata, through glossopharyngeal afferent cranial nerve number 9. This is what you should know about this one, and here is more information about it. So this is the carotid one. It has peripheral chemoreceptors. They detect oxygen level, calcium, carbon dioxide level, and H level, like the acidic medium level, and then it sends signal through glossopharyngeal to respiratory central in medulla oblongata and bones. So this one will regulate your breath. So for our question, the patient is breathing rapidly. When you breathe rapidly, you are losing calcium hydroxide. So when you are losing carbon dioxide, when you are losing carbon dioxide, so your peripheral chemoreceptors is not regulated. So your brilliant assistant, he's asking the patient to breathe inside the paper bag so he can take carbon dioxide again. So when he's taking carbon dioxide again, so the peripheral chemoreceptors will send message through glossopharyngeal nerve number 9 to the central regulatory centers in bones and medulla oblongata to adjust to respiratory. That's it. I would like you to know this. Don't go more. And here we have respiratory alkalosis. Patient will have seizure, deep rapid breathing, hyperventilation, tachycardia, normal or decreased blood pressure, hypokalemia, numbness or tingling of extremities. And there is another topic, metabolic alkalosis. I will not speak about it. I will just give you a mnemonic about it. And at your convenience, you can read it. But the key bottom here, if I'm going to speak about pH, its respiratory is opposite and metabolic is equal. So I'm saying respiratory alkalosis. So when I have respiratory to go down, which means this one is acidosis, so we have respiratory alkalosis, and the other way, and the same way for metabolic. So when the pH decrease, it's acidic. Acidic medium mean respiratory alkalosis because it's go another way. When I speak about metabolic, when I'm telling you pH is decreased, so it goes the same way, so it will be acidosis, metabolic acidosis. And for the respiratory is the other way, and here is a mnemonic. Please do not dig deep on this one because you will feel lost. And even if you call some of your friends, he's a medical doctor, and asking, you will ask him, okay, man, please explain this to me. And you will like, oh, did you do a career shift? Like, this is insane. How you study this part? You don't need this part. Honestly, you don't need this part. I just want you to know the peripheral, centrals, and the mechanism, how it works. The pH mechanism, increase, decrease, it's waste of time. Do not study this part. Increase CO2 in blood to go to peripheral chemoreceptors to send in the carotid artery to send message through glossopharyngeal, cranial nerve number 9, to the central in bones, amygdala oblongata to adjust respiratory. Next, pharma question. 6 years old patient present to the clinic with pain due to dental infection that requires antibiotic. The medical history indicates the patient is using antipsychotic drugs, haloperidol and donazepam. The antibiotic and painkiller of a choice is which of the following? And this question is aiming to very simple logic. Which antibiotic is indicated for dental infection? Penicillin. Which painkiller is indicated for dental infection? Ibuprofen. This is the key line. There's a mainstream unless we have any other condition contradict this stuff. And then he asking you question about drugs, you know nothing about them, and then he's tricking you to choose different medication. But like haloperidol and donazepam has nothing to do with ampicillin or penicillin, has nothing to do with ibuprofen, then he's going to trick you. And hence come the importance of understanding the drug-drug interaction and how does it work and how you can conclude that drug-drug interaction. But this question is simple. I'm just giving you this question so you think is not every medication you don't know is going to contradict what you know. So amoxicillin and amoxicillin is correct. Tramadol, no, we never give opioids, pure opioids as a first line unless we have conditions. Clindamycin, good antibiotic, but not the first line, and there's nothing contradict amoxicillin. And tramadol, so it's not correct. Amoxicillin, ibuprofen, this is a correct answer, and then clindamycin, ibuprofen. Ibuprofen, correct. Clindamycin, there is nothing to contradict amoxicillin. So this question is aiming for, I aimed here to make sure you know the mainstream and you know this drugs has nothing to do with amoxicillin. Not every drug you will see in the question is going to contradict amoxicillin and ibuprofen. You should know this stuff because like when you lose this such a question, you feel bad, okay? So here, let's go through algorithm again. Mild to moderate, acetaminophen. Acetaminophen 1000 is not good, is good, go. Okay, if moderate to severe pain, you give NSAIDs unless it's contraindicated. So NSAID is it's contraindicated, so you are going to give combination with codeine and NSAIDs. If it's not, so you add codeine to acetaminophen or oxycodone to acetaminophen. So like for this patient, is NSAIDs contradiction at all? You cannot give it to your patient, so you are going to get this combination, codeine and acetaminophen. If NSAIDs is not completely contraindicated, so you can give this one, NSAIDs and codeine each other, okay? So we never give our patient pure opioids at the first line. We never do this, okay? And here is the infection. Use only when there is indication such as signs, systemic infection, fever, malaise, lymphadenopathy, cellulitis, trismus, for those are immunocompromised. Other than this, we don't give antibiotic for our patient. Do not use substitutes for establishing adequate drainage. Like meaning if your patient coming with a swelling, I'm not giving to give him amox and ibuprofen, letting him go home. We should open and drain and then give him the antibiotics. Amoxicillin or penicillin are the first line agent for most dental infection. Consider loading dose for some antibiotics. Prescribe at an appropriate frequency, so you give your patient appropriate frequency. Prescribe for an appropriate duration, 3 to 5 days is usually sufficient. Recognize the antibiotics encourage development of resistance if used for too long and or at suboptimal doses. So you should explain to your patient if he used it for 1 or 2 days like analgesics and he didn't complete the course at least 3 to 5 days. So your patient, when he next time has infection, he will need different antibiotics, which is not cool. Consider individual patient factors such as age, allergy, drug interaction, especially with azole, antifungal, and then clarithromycin, metronidazole, tetracycline, and consult individual product monograph and drug interaction references. And even like in your office, when you finish everything, when you go to your office, you will not use your knowledge here. You are going to do the analysis and you can check the drug-drug interaction. And trust me, even the pharmacist, he's not memorizing everything. Even the pharmacist, he has a different software to do it. And even if you forgot about it and you give your patient medication that interact with other medication he has, and the pharmacist didn't catch it, the system will catch it and give him the red flag. You don't give this medication with this medication. We're just reading this stuff so you can understand the concept and you can read the question and answer in your exam. And that was the answer amox and ibuprofen. Perio. Which of the following is not likely to be seen in tooth with a periodontal abscess? So we're speaking about periodontal abscess, which is not likely to be seen. No response to electric pulp tester, meaning this tooth is necrotic. Let's see. Pain to palpation. Yeah, I mean like buccal swelling, lingual swelling. Let's see. Swelling in associated soft tissue, meaning like it's lateral. Let's see. And radiographic bone loss. So let's see a picture for this one so we can reach conclusion. So this is a periodontal abscess. Periodontal abscess happen when patient with periodontitis has a recession and has a perio condition, and you do cleaning for him, and your hygienist was not paying full attention. Your hygienist was in hurry to finish her note and do the perio chart and go home. Or maybe your patient is immunocompromised, like uncontrolled diabetic patient. Eventually, what's happening for your patient? Like it's going to leave some calculus here, or immunity is compromised, leading to blockage of the drainage of stuff from inside the perio pocket, leading to this swelling. As you can see, there is huge bone loss related to this one. Okay, so in the periodontal abscess, you can see a bone loss in X-ray for sure. This view in X-ray will have huge bone loss. How to differentiate between them? So let's speak about periodontal abscess and pulpal abscess. Periodontal abscess is associated with pre-existing periodontal pocket, as we said, deep pocket. Radiographs show periodontal angular bone loss, as you can see, and facial indelucency. Tests show vital pulp, and this is the key point. I will get this point and get away with this question. So for this condition, as we explained, the swelling is not related to pulpal origin. It's not related to odontogenic infection. It's related to inaccurate scaling or patient with immunocompromised condition. Swelling includes gingival tissue with occlusal, occasional fistula, not very common, being usually dull and localized. Sensitivity to percussion may or may not be present. Here we are saying may or may be not, so we are not going to choose this one. We're going to choose this one is definite answer. Test show vital pulp. For pulpal abscess, it will be different. It will have large restoration, no periodontal pocket, probe would be narrow defect. Tests show non-vital because it's dead tooth, swelling oval localized to the apex, and there is fistula tract. So in the previous picture, I can see here, like usually when swelling is going more apical. For perio abscess is going more occlusal because like the problem is in the pocket itself, blockage in the pocket. Pain often severe and difficult to localize, sensitivity to percussion. How we are going to treat it? Drainage through the pocket, retraction or incision. So we are going to do scaling for patient and root planning, and maybe we are going to incise this swelling. Might need periodontal surgery and systemic antibiotic and tooth removal. And when we are going to give systemic antibiotics, only with cellulitis, deep inaccessible pocket, fever, lymphadenopathy, immunocompromised patient. And this concept, I know most of us are confused about it, so we are not going to give antibiotic for our patient for perio condition, for odontogenic infection, unless we have severe signs and symptoms. As we see here, cellulitis, fever, lymphadenopathy, immunocompromised patient. Okay? So let me give you a question. I will read the answers for you give me now. So patient with HIV, and he has perio condition, periodontal abscess. Are you going to give him antibiotics or not? Your patient is HIV patient. Are you giving him antibiotics or not? So no response to electric pulp tester because it's not. Please pay attention to not, okay? Last question from operative. Which of the following statement is true? All elderly patients have reduced salivary flow. Pit and fissure sealant should never be used for adults. Elderly patient may be able to undergo a simple restorative procedure without anesthesia, all of the above. So let's take it one by one. And let me give you a hint here. All elderly patients have reduced salivary flow. We tend to think this way, but this is not correct. Salivary flow reduction is happening due to side effect of medication your patient is using. You remember the patient in question 3 is taking some antipsychotic drugs. This medication usually lead to xerostomia. So not every patient is elderly, beyond 60, he will have reduced salivary flow. And I know this is hard to believe, but trust me, when you go to check the change in the salivary flow in the patient, when you check the textbook, they're saying there is no alternation in the salivary flow for patient with age. It has to it has something to do with side effect of medication he's taking. Pit and fissure sealant should never be used for adult. No, why never be used? We can use it for adult. Think about the patient with a good oral hygiene and he coming to you, he's 25 years old and he has some stains in his fissures. You can use for him pit and fissure sealant. Why we cannot use it? It's more indicated for kids, but like we can use it for adult. And as a general rule, like all, should, never, like this is not like scientifically this is not even correct. Elderly patient may be able to undergo a simple restorative procedure without anesthesia. And you can say, okay, first two, I don't know about them, but this is no way, man. Like how you are going to teach your dad about doing a filling? No. Here, let's speak about that change in the pulp and what's happening. For young patient, you will have huge pulp chamber and less of dentinal bridge. You will have good enamel. But when your patient grow old, the pulp will have go degeneration and the pulp flow will be different. The type of cells will be different inside the pulp for your patient. So this is what happened. For young patient, you have odontoplast and you have enamel, you have PDL, and this part is going this way. You see odontoplast, you see dentin, you see dentinal tubules coming inside odontoplast, and this what we are going to see. You see cementum is good here, you see enamel is here. But when your patient growing old, you see a different change. This is a young patient, and there's a cross section here, dentinal tubules, and there's dentin. With patient growing old, the space will be less, and then the dentin bridge will be more, and then there is attrition happening here, and the attrition happening in enamel is compensated by more cementum coming from the apex of the tooth. Also, the entire tubules will be blocked, as you see here, this orange dot here, meaning like the space where the fluid can go from inside to outside to give signal to odontoblast to give patient pain is narrow. You can see here, like this is orange space, and here is coming narrow and narrow and narrow. So for each patient, you can say we can do filling without freezing because of a change of the dental pulp itself and change happening in dentin, more reparative dentin, more sclerotic dentin is deposited inside the dentin for your patient. So he will has less capability of sending the signals to odontoblast to send it to the pulp, which also has some degeneration. It has less fibers now and has less vascularity. So we can reach conclusion this patient can undergo a simple restorative procedure without anesthesia. And I can remember one patient, the dentist I was working for, he was doing a filling for him. And then he asked the dentist not to give him freezing. And I was confused why. And then I remember we did 10 fillings for him in the quad 2 and 3 without freezing. It was cervical, it was class 2, it was class 1. He needed no freezing. And when we look inside the dentin, after removing the caries, it was like black dentin, hard, discolored. It was weird case. I still remember. It was maybe 2 years ago, but I still remember this case. So that was it for our weekly newsletter today. I hope the 5 questions were like giving you more concept. And I hope you get the idea how to study oral pathology and how you are going to tackle your medical emergency, how you are going to get the medication and intersection between them. I hope you get the concept more than the question, please, from this newsletter. Feel free to give me your feedback. Feel free to share it. You can download the PDF here and feel free to watch the other newsletter. See you next week. Bye-bye.